the board, and hopefully you can see just in terms of the dynamics of it. I think we ask that if you're not talking, you mute yourself. And also, am I correct, Robin, in saying you turn your camera off?
Yes, please.
Okay, and then obviously when you're going to talk, turn them both on so we can both hear and see you. So that would be helpful. Thank you. Declarations of interest. Any changes, additions to the declaration of interest? You'll see on that they are available on the internet. We're not going to every month reproduce exactly the same report. The intention is that if people want to, it's readily available to the public, and we will just declare significant changes or any changes during this process. So I think that's the way we're going to make sure it's visible. Apologies for absence. Shirley, have we had any?
No apologies. Thank you,
okay,
John.
Thank you. Good. Minutes of the meeting of the 4th of February. Any comments on accuracy there? I'm not seeing any comments in the chat there, so I'll assume there's not. Let's check. Okay, so let's take those as an accurate record of the meeting. Thank you. Matters arising, the log there. Shirley, do you just want to run through this with us?
Yeah, so all the actions have been updated and they're either on the agenda or going to other committees, etc. Just Richard to give a verbal update on the second action 802 regarding the ICP.
Richard?
Yeah, morning everyone. Just check people can hear me okay?
Yep.
Fab, thanks. So you've had a conversation with some ICP colleagues about this. We're going to establish this way of working as we move into 21-22 for the ICP objectives. And I think we're keen to do two things through this. One is to evidence, as the specific action suggests, where we can deliver success as an ICP rather than individual organisations, so the collective success across health and care, the things that are important to us. But the second point then is not all of them, but a large proportion of where we will focus our effort in 21-22 as an ICP will be also delivering on the ICS agenda. And there's conversations taking place about how the ICS and the 3 ICPs can continue to work. So I think this action is complete, and you will see when we next give the ICP update how it's progressing. You're on mute, John.
Yes, all right. Thank you. Any comments or questions on any of the other matters arising? Okay, thank you. Just a couple of comments on my report. First of all, I think we ought to formally acknowledge the money that we've received through the Captain Tom appeals, etc. And the report says some of the things it's been used for. I think is a fantastic thing there that he's managed to do, and obviously sad that he's passed away, but he leaves a huge legacy, and I just wanted to formally recognise that and to formally thank him and his family for everything they've done. The second point I want to raise is just a general comment. I think the last year has been very difficult. We've achieved a huge amount, but we are entering a period of really quite a lot of change and quite a lot of uncertainty. We've got things like how we balance returning to some degree of normal services, whilst at the same time, COVID is going to be with us for a long period. We've got the next steps in the move towards system. We know that staff have been working incredibly hard, and how do we make sure that we can give them the space and the time to recover from the last year or so for those who've been right at the thick of it. And the financial outlook in terms of for the NHS as a whole is still somewhat uncertain. We haven't received planning guidelines or allocations or anything else which you would have expected by now. I think what that says to me is that we need to be very careful about making sure that we're really fixed on the things that are absolutely critical in terms of making sure that we continue to improve services, that we don't in any areas slip back, and that we're focused on what needs to be. And I think the next 2 or 3 months are going to be really important for setting the way in which we move from where we are now into not a post-COVID world, but a world in which COVID is there, but also we're doing some of the other things that we're going to need to do. One in which we continue to strengthen our partnerships outside of the trust. And so certainly I think for the board, there are some discussions that we are having, and I would hope we'll have some similar discussions with the governors about, you know, how do we make sure that the last 10 or last 7 or 8 years of the journey that Sherwood's been on, that we build on that, coming out of what's been a really difficult period of time, and that we continue the journey and make sure we're not slipping back. So there are some, you know, really important thoughts that are occupying my mind, and I know a number of my colleagues, not just in this trust, but I suspect in just about every other part of the NHS, because it is probably the most, the challenges have been huge for the last year. They will continue to be huge, but they'll be slightly different. And so there are discussions both here and more widely about what that all means and how we make sure as a trust that we build on the fantastic achievements of the last few years. So I just wanted to sort of send that out as a really important message about the focus of the board in the coming months will be very much on making sure we can make that transition into 2021, 22 and beyond. I'm happy to take any questions, but I didn't really want to raise anything else from my report. It's there for you to read. Any comments from people? Okay, thank you. Richard.
Thanks, John. So a few points from me, and as I've done in the last couple of months, going to hand over to some exec colleagues to give some specific updates. So as we've recognised in the report, we're moving towards having patients with COVID in our organisation now for 12 months. The first patient with COVID was diagnosed at Sherwood on the 14th of March 2020. So we're going to take the opportunity next Friday, on Friday the 12th of March, to have a service that we'll live stream, and then we will post out to people to watch subsequently, to reflect on the last 12 months. Also just to recognise and to thank colleagues at Sherwood and the wider community and beyond for their support for the organisation, but also to recognise that things are beginning to look better, and that we think we can continue to be optimistic and hopeful, tying back to what you were saying, John, about the success of the organisation over the last 5 years or so. And I'm confident that over the next 5 years, Sherwood will further grow as an organisation through collaborating and cooperating with partners, and will truly be that anchor organisation for the community that we've described. Obviously, though, we also know that things remain quite challenged, and a conversation we've been having across the executive team is about ensuring that that us as the most senior leadership team need to remain focused on the key priorities for us, and then through that we then need to be cascading it out into the wider organisation. People will remember that this winter we focused on 3 things. The first point was providing safe care to all patients. The second bit was about continuing to look after others and ourselves, and the third point was about being proud. I think those 3 things were important, but practically when you unpick them, it's possible to have a multitude of sort of separate areas of focus and objectives running through them. So we're going to have a conversation as an exec in 2 weeks' time. We've got an extended session about just really, given the limitations on what the NHS, wider public services, the region, Sherwood will be able to achieve over the next 12 months, what are those key priorities for us to focus on? And certainly right at the centre of those will be the continuing the provision of safe care to all patients in a world where COVID in some form is going to continue. So we're going to have that conversation, and we'll bring it back to boards and to non-execs. And also tied into that, I think probably privately there's a whole range of things that we worry about at work that maybe we can reflect about how we can share our individual concerns about things that are happening with others more effectively, and then really theme and identify what the key concerns are and how we can respond to them as an organisation over the coming year. So we're also going to be picking up on that. What are the things that I worry about, or maybe the stuff that I know about at work that others don't know, and vice versa, and we'll tie that together. And I think that will further and inform the prioritisation about where we want to take the organisation. over the next 12 months, both within our work at Sherwood, but then also the point about system partners. Before I hand over to Simon, who's going to update on the situational report from COVID, and then Claire is going to update around COVID vaccination, and finally Paul attended a Midland leaders update early in the week, and he'll talk about some of the conversations that are taking place across the region. As you can see in the report, I think there are a number of things that are happening in the organisation at the moment which are important and a good recognition for the organisation. So whilst things are difficult, I think there are many reasons to feel optimistic and hopeful. And I certainly think the success that the organisation has generated over the last 5 years or so, I think this organisation will go from strength to strength. So I'll pause there and hand over to Simon, if that's okay.
Thanks, Richard. Just a bit by means of a bit of an update around COVID within Sherwood Forest. So today we have 64 inpatients who are COVID positive. That's down from a high of 208, so falling position, but still relatively high. 15 patients are in our critical care unit. Its normal capacity will be 9, so still a lot of pressure in critical care, and that is affecting our ability to run theatres as normally at Kings Mill. So they're doing about 40% of their normal activity. And we've seen an improvement in the staff absence rates. That's around 7%. That includes colleagues who are both off sick but also self-isolating. That's fallen from about 9 to 10%, so that's been really positive, as has the fall in the general population. And I think it's good for those colleagues, but also has helped us to ensure that that the capacity that we've got open to treat patients has been well staffed and supported. We are in some areas de-escalating our surge capacity, so our respiratory assessment unit has stopped today in light of the falling COVID admissions, but as mentioned, we've still got areas of the organisation which are working at an escalated rate. But I do think it's really important as we de-escalate the RAU to really thank our colleagues in respiratory for the amazing work that they have done in running that service, and also to thank colleagues who continue to work in surged areas. We continue to manage oxygen well and get daily situation reports, twice daily situation reports on that, and that continues to be managed well. And from just a bit outside of COVID, our outpatients continue to operate about 80% of pre-pandemic levels, and I've already mentioned elective operating at Kings Mill, but elective operating is at pretty normal levels at Newark as well. So we still are offering elective care to a wide number of patients. So I'll hand over to Claire in terms of workforce.
Hi, thanks, Simon. I'm going to cover off a couple of pieces around the COVID vaccination programme. So just in terms of where we're up to, there's a paper in the pack which is here for assurance and provides some further detail about the work that's taken place to date. The planning for the programme started in October. And from that time, we did the first vaccination in Nottinghamshire on the 8th of December. And I think it's fair to say that collectively we've come a long way. From a Sherwood Forest perspective, we've supported the programme in a number of different ways. One of those ways is that we have been the lead employer for recruiting, onboarding and training a number of colleagues to work with us, not only at the hospital hub, but across the vaccination programme across Nottinghamshire. And to date, there are 3,000 people that have been recruited and that are working for us in that capacity. I think it's a fair reflection to say that that was extremely challenging to do and turn around in a short time scale, and want to acknowledge the thanks to colleagues working on that programme for doing that and setting that up. In terms of some of the other work that particularly colleagues at Sherwood Forest have done is that we have run one of the hospital hubs. So we have a vaccination centre at Kings Mill. As I said before, we started to vaccinate on the 8th of December. And we've supported not only the vaccination of Sherwood colleagues, but also the citizens of Nottinghamshire, providing support with vaccinations for cohorts 1 to 4 and now down to 5 and 6, which is essentially everybody over the age of 70, those that are clinically extremely vulnerable, and the health and care staff. In terms of vaccinations to date through the hospital hub, there've been over 45,000, and whilst this week there's a slight drop in the vaccination numbers, supply as of the 15th of March will increase significantly. So at that point we will be not necessarily through the hospital hub alone, but across the whole vaccination programme, literally doubling our efforts in terms of the number of people that are vaccinated. It's been fair to say it's been a whole team effort, and working at the hospital there are a number of colleagues from organisations across Nottinghamshire and people that have for the first time stepped into work into health. So a number of people that have either been furloughed or have lost their jobs as a consequence of the pandemic in other sectors have been trained and are working for us. So there's some really positive stories, and we hope to be sharing some of those in the near future. As I say, we've as Sherwood Forest, we've supported the programme in a whole host of ways, and have provided leadership around some of the pharmacy support, finance and quality assurance roles, procurement, and also in terms of payroll for the staff that we've onboarded. And I just want to take the opportunity to again express thanks to all staff that have worked on the programme. I think it's my turn to hand over to Paul.
Thanks, Claire. As Richard suggested, I attended the NHSI Midlands Leaders update yesterday or Tuesday afternoon, and the sort of main headlines that at regional level that chief execs were discussing was the planning for 21-22 issues around the first quarter being a roll forward of the financial regime that we've had in place for the last 6 to 9 months. Negotiations with Treasury still going forward, and the focus away from the money, but the focus was quite rightly on how we restore services with the right balance, much the same and certainly consistent with John's comments a little earlier. A major part of the update was around vaccinations. Dale Bywater was very complimentary about the whole Midlands response to vaccination rollout, and last week was the best week so far. So across the Midlands, approximately 487,000 vaccinations were provided, and as Claire just mentioned, that now is ramping up. So certainly by the end of March, that will have doubled or almost doubled to something like 900,000 vaccinations, and that will continue through the spring and summer as second vaccinations come on stream. Lastly, Jeff Worrell presented some slides and talked about time critical surgery. These are the urgent patients waiting surgery. We sometimes designate them as P2. Sometimes they could be cancer patients, but other time critical and urgent patients who've been denied access to that critical surgery due to the responses of the pandemic, and that there is now a requirement that we should progress with no patient should be denied access to that time critical surgery due to the lack of our critical care and theatre capacity, and that routine surgery should be only reintroduced when those time critical surgery patients needs can be met. And there's going to be more focus on that from NHSI, and a recovery cell committee being established across the region in order to track that, and a number of data requests have already been. The sort of working estimate is there's around 15,000 patients in this category waiting across the Midlands. I'll leave it there, John.
Thank you, Paul. Just looking at the questions, Barbara, you wanted to follow up on the vaccinations?
Yes, please, if I may. So first of all, just to acknowledge, it's been fabulous, the extent of the scale of what's happened to date, a lot to be proud of there. But two questions I'd like to ask. First of all, could we have the latest uptake for our own health staff employed by Sherwood Forest Hospital Trust in terms of vaccination programme? And sort of part B to that question, if you like, is that we've heard on the national media about work in Leicester to segment their workforce stats to really understand if there are particular staff groups, either because of BAME or deprivation. So understanding the differentiations in terms of vaccine uptake. And then second question, sorry, Claire, second question is really about, again, the national debate that I'm aware of around whether or not staff, it will be compulsory for staff to be vaccinated, and what discussions are going on that particular issue.
Hi, John. I'm happy to respond to those questions. Is that okay?
Thank you. Yep.
So thanks, Barbara. So overall, in terms of our staff uptake for Sherwood, we are at 83%. Some of the things that we have done and continue to do to support that is that we have opened up the clinics so that staff now no longer need to book. So if they've not had a vaccination and are on site, they can just drop in because we've got capacity to be able to field that. Now we're down to smaller remaining numbers, and that's worked quite well. In terms of understanding staff groups that have both taken up the vaccine and are remaining, we have looked at some of the data by BME members of staff, by those that are shielding, and also by age category. As it stands at the minute, the age category being used in reporting on nationally is those over 60. I suspect that that will start to come down. But we've done pretty well on all of those categories. For our BME workforce, 78% have been vaccinated. For our shielders, we're at 86%, and those that are over 60, we're at 94%. And we are doing some supportive work with all of those colleagues to understand if they have any concerns and support giving feedback on any of those concerns to enable people to have the vaccination. So we're continuing to do that work through. In terms of, I think the second point was about the mandating of a vaccine. So we're not at that point as it stands at the minute. However, that conversation is being had and is very, very live. In fact, there was a national webinar last night with Chief People Officer having this very conversation, and as people directors, we've all had an email this morning to encourage us to start to now have one-to-one supportive conversations to try and encourage the uptake of the vaccine. Where we go in terms of mandating it, I think it's still unclear, if I'm honest. I think as it stands at the minute, we are in the position of still encouraging people and supporting people through occupational health to understand and take it up. But I do expect that over the next few weeks and months, we will hear more about that as we get in, particularly to planning for the autumn and what onward looks like in terms of both flu and COVID. So I think that conversation will stay live, Barbara, over the summer, but we've not got any absolute set direction yet.
Barbara, do you want to follow up on any of that, or are you okay?
No, I'm okay. I'm just aware of the issue about staff take-up, because keeping our patients safe is a huge priority for us, and it's great that we've got that 83% uptake, but of course it means that we have 17% that don't have the vaccine, and any one of them, you know, and we know that lateral flow tests aren't the best. So I'm, you know, very keen to support, do whatever we can to have those one-to-one conversations, Claire. I think that would be good.
Okay, thank you. Claire Ward next.
Thanks very much, John. Yeah, a couple of points really. One is in terms of that analysis of who's had the vaccinations and who hasn't? Is it possible to get a bit more drill down on the data of where those people are working, whether they are working, you know, on the wards, frontline, or they're in support roles or in different other roles within the trust? What analysis? I know that later on in the SOF we'll come on to details about infections in hospitals. Are we doing some cross-referencing of where we have high levels of vaccinated staff versus areas where we may be having outbreaks of infection in the trust? And finally, can you confirm that all vaccinators, as part of their onboarding, are required to have, I believe it's a Hep B vaccination before they're allowed to vaccinate, if that's the case? Thanks, Claire.
Thanks, Claire. So in terms of getting the detail, in terms of the more granular detail about who has and hasn't had the vaccine, we are in a better position to be able to do that now. We weren't originally, because we had to cross-reference two records, and that's one around the staff database and having access to the national immunisation record as well. We're now in a position where we've got that, so that's why we can understand some of the more detailed position, which we will do. We haven't to date done any cross-referencing around that because we haven't had the information, and I think it's fair to say that our efforts have been focused on just literally getting as many people through the vaccination centres as we can. But that is something, Claire, that I think it would be really sensible for us to look at. And in terms of the requirements for people vaccinating, yeah, there were national requirements that we had to adhere to around occupational health checks before anybody could vaccinate. I can't say hand on heart what those are. I will double check, but we have worked the nationally prescribed requirements before anyone's been onboarded and allowed to vaccinate.
I'm going to go to David first, because he's going to pick up one of the specific questions, I assume, on the infection bit, and then I'll come back to Graham, if that's all right.
Yes, happy to pick up. I think it was Claire's second question, which is around, do we have a site of hospital-based infections and our staff having had vaccination? And so this is something that we have started to capture, Claire. Julie and I were on our outbreak meeting yesterday, and we were discussing this with the regional infection control lead. So there are two aspects to that. There's something about capturing the staff vaccination rate, but then there's also something about capturing the take up of the lateral flow testing in a particular area. So both of those aspects we're starting to look at. To date, we haven't had the ability to capture that, but hopefully we will develop those systems going forward as we get more detail in that. I hope that answers that question.
Okay, thanks Dave. Graham.
Thanks, John. Just a little bit more follow-up, if I may, on the vaccination side of our staff. I think at 83%, that's good performance, but it would be nice to see it even higher for obvious reasons. Just really want to understand what we're doing to push staff go through. I recognise what you've done in terms of saying you can just drop by at any point in time, which I think is really good, but it's just what else we're doing to not so much harassing staff, but really positively encourage them to get that percentage as high as possible. Because I know from my other hospital, I receive emails on a daily basis, literally, and they're well in the 90s now.
Thanks, Graham. Yes, they're doing very well. So yeah, we've done some targeted comms. As I said, we've done some targeted comms. We've particularly as an example for staff that we know that are shielding. So we've worked with those colleagues directly. We've also engaged with our staff networks, for example, our BME staff network, and have done some particular work around myth busting to support and encourage colleagues to uptake the vaccine. We've opened up the clinic, as I said before, so that you don't need to book an appointment and people can drop on when the more convenient, when it's convenient. We do sort of on the day, not just emails, but ring-arounds, so from the vaccination centre, particularly if there's a bit of a lull in activity, just to encourage people to drop on. So we are doing a whole host of things to really keep the interest in obtaining the vaccine live. As I said, I think we're going to be in a position where there'll be some further national direction on that, so we'll also be ready to respond to that.
Okay, thank you. Tim, and then Richard.
Thank you, John, Claire and everybody. Just a couple of, well, a question and some observations here is that it's good to see that we're at the 83%, but that's still lower than our flu vaccination. So I was hoping we'd at least be on par with that. And the other one is there's been a lot of focus on protected characteristics and infection in COVID. And at some stage, Claire, it'd be good to get an understanding from our own workforce as to where we are with that, especially when I've read some data that says 60% of deaths from COVID last year were down to people with a disability.
Thanks, Tim. Yes, as I said, we will get, as now we've got access to more detail, we'll make sure that we work through all of those. Just one final thing from me, just to support that, because I think it's really important, is that through the hospital hub, the team have been doing some incredible work to support young adults with learning disabilities to receive the vaccination. So, for example, Pfizer is the one that is currently licensed for those that are 16 and 17, and in terms of the whole of the Nottinghamshire community, the team have really made sure that young adults with learning disabilities have been supported to receive the vaccination, and it has been a place where people county-wide have chosen to come to receive it, and as well as supporting the young people, we've also been able to vaccinate their carers, and I think that that's just, I want to share that because they've done the team have done an incredible job around those particular citizens.
Thank you. Richard?
Just first of all, thank you, Claire, for answering all these questions about vaccination. I think as we've acknowledged, the programme has gone very well, and I think there is room for the further uptake around the vaccination point. Your point, Tim, about sort of using COVID vaccination and flu vaccination as a comparison, I think is a fair one. We've had a conversation about, I think we should get our COVID uptake at least as high overall as our flu uptake. We saw last week confirmation that the flu uptake at Sherwood was the highest from all acutes across the region, and I'm confident that our COVID vaccination uptake will be similar. As we've heard from Claire, however we cut into it, whether it's by site, so our 3 sites, or clinical, non-clinical, or colleagues from minority community, or age, or etc. What is really impressive, I think, is that standard high rate is similar across all of the board. So I think we've made, I'd personally say, an exceptionally strong start with this, and I think we'll see some more progress over the next couple of weeks. Thank you to Claire, to Rob Simcox, to Kim Kirk in particular, for their leadership around this.
Thanks. And just a point, Claire, just to clarify for me, when you talk about the number of staff, do we include in that MediRest staff, and do we include volunteers, or I just wonder how wide is our, because they're all people who are going to be working in the hospitals at various times, aren't they?
So John, the figure that I've quoted you at 83% is our staff.
Right.
However, from day one of vaccinating, we have made the vaccination available to our volunteers and also to our MediRest staff, and the uptake has been very good from both of those particular groups of colleagues as well.
I just think, from thinking about the overall safety issues and infection issues in the hospital, it'd be useful to have some figures on those two groups as well, because they often spend a huge amount of time with individual patients, and it'd be good to know that they've got what their levels are when you come back with some figures. Is that all right?
Yeah, I'm happy to bring back a more detailed breakdown to a future board. I can see there's quite a high level of interest, quite rightly. And now that we've got access, as I said, to more of that detailed information, I can provide the breakdown to a future board.
Yeah. No, I think there is a high level of interest. I think that's partly because people only see this as about the only way out of COVID, really. So yeah, Richard, sorry.
Sorry, John. Yeah, the other thing I was going to say, Graham, helpful reminder about the success down at King's Lynn. I'll take an action to contact Caroline Shaw, the chief exec down there, to understand how they strike that balance between personal choice and a high uptake, because there may be some learning for us.
Thanks, Richard. Okay, well, I thought that was a helpful conversation, and Claire, you're right. This is something that, you know, it's been some really good work, and we're very keen to support in any way about moving it forward. So thank you for that. Okay, Richard, anything else from your report, or have we covered everything, you think?
No, just covered that. Probably just worth acknowledging that today is Andy Haynes, RX Medical Director and Deputy Chief Exec's last day of working in the ICS. I think Andy's been, we all know, he's been a fantastic servant to the wider NHS, certainly anyway, Nottingham University Hospital, Sherwood, and more latterly the ICS. He's a great friend to many of us and will continue to be. So on behalf of the organisation and the system and our communities, thank you, Andy, for your service, and we wish you and Fiona a long and happy retirement.
Yeah, now I think we perhaps might just send Andy a note on that as well, just say the board have thanked him for the huge amount of work he done. Although I don't hear he's going to fully retire. I'm sure he's looking for a few things to keep him busy. So we'll see. Okay, thanks for that, Richard. Okay, shall we move on then to the maternity update? And really three aspects on this. So Julie, can I leave you to take us through these?
Yes, please. We're going to take each report in turn, if that's okay. Claire and I are going to do a bit of a double act. We've got a few slides for you just to introduce the role of the maternity and neonatal board safety champions, and then Claire's going to update on our activities for February. So if I could just have the first slide, please. So I don't think I need to talk to you too widely about the national position with maternity and the increased scrutiny on maternity. Sorry, next slide, please. Yeah. So we've recently signed off the Ockenden report. There is a big call from the RCM to increase leadership in midwifery and strengthen it so that we have leaders who are able to represent at a board level within midwifery. And then we have the NHS resolution standard, which is the clinical negligence scheme for trust, which is all around making maternity safer. And then we have the transformation programme, which is about reducing morbidity and mortality within maternity and neonatal services, but is also around transforming care so that it meets the expectations of women, their families and their babies. If I could have the next slide, please. So the role of the board safety champions is all about being an ambassador for safety. And the three key components of safe services are that there are effective relationships amongst those working in the services across the multi-professional team, that we have strong leadership that has capacity and capability, and that governance processes are robust. So that is the kind of the key role of mine and Claire's roles as safety champions. Next slide, please. And in the board forum, these are the things that we need to be providing assurance to you. So we should be providing assurance that clinical care is of high quality, that our service and facilities are fit for purpose and able to meet the needs of women, their families and their babies, that our workforce numbers are adequate to meet the needs of women and babies that choose our care, but also that we are future-proofing the workforce for the future, that we are training our staff appropriately and that we're learning from near misses and incidents and when things go well, and that our teams are working together effectively. Next slide, please. And the way that we plan to do this is that we will have a regular safety walk around. We'll attend the safety huddles that take place on a daily basis within maternity, so we will dip into those when we're available. We have a monthly meeting with the maternity safety champions. So Claire and I are the board level safety champions, but they're also safety champions within the service. And we also have access to the regional safety champions. And we will identify opportunities to engage with women and their families. So there's an afterbirth service, which I plan to spend a bit of time in. And Claire has recently spent some time chatting with women in the antenatal clinic. We will have oversight of future national and local maternity safety initiatives. So there are lots of these. And following our walkarounds, we are publishing a You Said Together We Did. And that's just with the clinical illustrations team at the moment. And then we plan to feedback our monthly activity as part of the maternity report to the board, and we'll share the National Safety Champions newsletter across the maternity and neonatal services. I'm just going to hand over to Claire for the last slide.
Thanks very much, Julie. Yes, so as Julie has said, we have a programme now of monthly walkarounds for the maternity unit and also attending the maternity safety champions meeting. So this will allow us to be able to update the board on those activities. And the recent visit that we had, I was very impressed with the opportunities that the staff took to come and talk to us. They didn't know that we were going round the neonatal and maternity unit, including the labour ward. But when we approached them and asked them about the various issues or what they wanted to talk to us about, they were really open and transparent. And I think that's a very good sign of the culture and the confidence within our organisation. They did raise some issues, particularly around transitional care unit and how we make sure that we've got the right staffing to be able to support those babies that and mothers who need additional care before they leave our service. Staffing, I think, was probably quite a common theme across all of those discussions. And those are issues that I'm sure are not going to be solved very quickly. But I think it's important to build confidence to show that we're picking up on those and that we're actually looking at what we can do. We had an opportunity where we were wandering around the labour wards talking to people about equipment shortages, and it's a real shame that we are seeing some of our very expensive and very crucial equipment being lost on occasions to theft, but also, of course, some breakdown. And I think it's important that we pick those issues up and make sure that we are able to go back to our staff and give them a plan for the future. So some really crucial issues. I think building confidence will be about the You Said and Together We Did feedback. But I think this is a good way of building a relationship between the safety champions and all parts of the organisation at maternity and neonatal level. I think we hand over back into discussion. I think the next slide is a discussion.
Yeah, I'm happy to take any questions on that one.
Yeah, Neil.
Yeah, thanks, John. Just wanted to ask about the friends and family test. Most of the quality and the safety metrics are pretty good, and yet we seem to have seen a decline in the friends and family response over the last 4 months. Do we know why we've got this apparent divergence of what we're doing and the perception of it?
Yeah, so we did a deep dive into this after the last board, and I can tell you that we have a problem with the text messaging service, which is how we are getting feedback from women at the moment, because we haven't got volunteers in the clinical areas with the iPads. So we sent 441 texts for this data set and we got 19 replies. So the sample size is extremely small. When we looked at the timing that those texts were sent, it was between 6 AM and 7 AM in the morning. And if you've just had a baby, I'm not sure your first priority at that time would be to respond to a text from the hospital, and it's a pretty inappropriate time to be texting. So we have changed that going forward and asked that it be at a much more sociable hour, perhaps in the middle of the day or shortly after lunch. And we are reintroducing paper within the clinical areas to try and increase our response rate to that. So I do think that is being driven by that very low response rate. And now we understand what's going on there. We have a plan to remedy it.
Thank you. Okay, Neil.
Yeah, okay, thanks. Yeah, I think that's fine. I mean, clearly, if you get a low response rate, you tend to get the people that are the complainers rather than the ones that are happy. And so if we can get a better response rate, the chances are we'll see an improvement in the FFT measure.
I suspect we woke some of them up as well, which won't make them very happy.
Nothing wrong with that. That's fine.
Manjeet?
Yes, just on that same note, I thought an opportunity to ask here, it's part of the SOF, is the trends in the patient comments. And I just wondered, also with the Champion Walkabout, a bit more about the patients, even though I know complaints haven't gone up, just more about what the patients are saying.
So Claire had some conversations with some patients in the pregnancy daycare unit. I don't know if you want to give your perspective, Claire.
Yes, I mean, I had an opportunity to talk to 3 ladies and 2 partners who were there as well in the day case unit, and they were very impressed with the service. They were very happy with the service that we get. One issue that they specifically raised is the speed in which they were able to access daycare services when they called to say that they may have an issue or a worry. They were invited to come in very quickly, and I think that again is about building confidence. So no adverse feedback at all from the patients that I spoke to.
Thank you.
Thanks. Dave.
Thank you. I'm not sure if this is a question for Claire or for Julie. Obviously, clearly supportive of this, but can I just check that we're capturing support and help from across the whole team, that it's not just the midwifery team, it's the nursing team and also the medical team to help drive change and to recognise what we can do to improve?
I can take that one. So yes, we are, and there is there's an obstetric safety champion and a neonatal safety champion that are part of this programme, so they are completely embedded within it. I don't know if Claire wants to add anything.
No, that's fine.
The only thing thank you, and that's really helpful. The only thing I might just add is that sometimes our trainees are a real rich source of innovation and opinion, and some of that opinion needs tempering, but usually they will give sensible help to this sort of program. So that might be worth a group to target as well.
Yeah. Thank you. Noted.
Yeah, I think that's a good idea. Okay, I can't see any more questions. The only thing I was going to suggest in addition is that you referred to sort of national initiatives, etc., and obviously take those on board. There's also, if I remember, a sort of national report on maternity services which comes out, which allows us to do some benchmarking on things like cesarean, etc. And it has quite a wide range of indicators, stillbirth, cesarean, all those sort of things. Do we look at that, and where does that look at to see whether we're in line with other places or out of line with other places or whatever else? Do we look at that?
We do. So you see a very small proportion of the maternity dashboard here, but there is a much larger dashboard. We've picked out what we would consider perhaps avoidable harms for you to see here, but we do look at a much wider cohort of metrics. And I think, to be honest, we benchmark pretty well. We can bring a bit more detail about perhaps things we're keeping an eye on following the next safety meeting, if that helps. There's nothing particularly that comes to mind that you're not seeing here that I am worried about.
Yeah, I think I'm not sure I think it's more of an exception if there's some real issues that you think you need to attention. I just wonder if perhaps once a year, given this, when the stuff comes out, that something like that might be useful for the board to see. But I'm not sure we want to bring loads to it. I mean, if Claire's looking at it and you're assured that it's being picked up through the management areas, etc., then I'm quite happy to other people, but I'd be quite happy just to rely on bringing through the exceptions rather than us to be presented with a full dashboard, providing that's being picked up properly. But it might be useful just once a year just to see that, just really for education more than anything else, just to sort of see that. So that might be one way to do that. Okay.
Sure.
But I'll leave you to talk with Claire about what the right balance and all of that is, I think, because we need to be careful not to inundate us with stuff which is being properly looked at and robustly scrutinised elsewhere, really. Okay.
Yeah.
Thank you.
Okay, so shall we do the second item, which is the perinatal review tool? So I was going to pick out FFT, but we've covered that. The other area I just want to draw your attention to is the APGAR score. So you'll all know this is a new and evolving report, and we're learning about how the best way is to report on maternity. This has increased slightly in month, but actually it does include preterm babies at the moment. An APGAR score for preterm babies is not as relevant. So to truly measure avoidable harm, we're going to exclude those preterm babies going forward, and that will bring that down. The other bit to pick up on is the incidents. So there were 61 incidents. They were all no or low harm. And I just thought I'd give you a sense of what triggers an incident in maternity, because there are a list of triggers that we have to report. So of the low or no harm, a number of them relate to emergency caesarean sections, so where women have attempted a normal birth and end up with an emergency section either for fetal or maternal reasons. Women that have arrived on our labour ward unbooked, whether they've been booked in another hospital or have concealed a pregnancy. Women who are transferred in labour from home, so are planning to have a home birth but are transferred for a maternal fetal reason. Or where a baby's required a little bit of resuscitation at birth just to help it convert from neonatal circulation, from fetal circulation to a neonatal circulation. So all of those events are known complications of labour, and all have resulted in no or low harm. So I think that is a very assuring picture, and there's been no serious incidents in maternity reported in this this month. Happy to take any questions on that.
I can't see any questions, Julie. So that's, I mean, I think it is a very helpful report, and whilst there's detail on that, I think given the national issues, it's probably important that you do share some of that with us. So that's good. Thank you for that. And the final report? Yeah,
so the final report is an update on Safety Action 4, which is part of our NHSR submission, and this is around having adequate clinical workforce. There are two areas to bring to your attention, and board will be aware of these because we did bring these last year. So the first is around the elective caesarean section service and meeting the anaesthetic standards. This is really around the anaesthetic PAs within the obstetric service, and we have received some very strong signs that the local maternity and neonatal system will fund this business case for 21-22. So just to advise you of our progress with that. And the second is around an advanced neonatal nurse practitioner workforce, which is being funded through a national pot. So it's really so the board are aware that these are our gaps and that we have plans in place to address them going forward.
Okay, thank you. Any questions on that? Okay, well, thanks, Joe. I mean, it's a really thorough report, and you and Claire doing this, so thank you very much for that. It provides, I think, quite a lot of assurance that we're aware of the areas, but also about some of the good stuff that's going on. So thank you very much for that.
Thank you.
Okay, shall we move then on to the single oversight framework performance? Richard, can I leave you to guide us through this? Is that easiest?
Yeah, very happy to. Thanks, John. Can I hand over to Claire and Emma, first of all, as always?
Thank you. Thank you, thank you, John. So I'd like to share 2 to 3 highlights this month, just in terms of what we've been focusing on as an organisation, and those are around our health and wellbeing roadshows. So we've been actively over the last number of months, and particularly it has increased over the last 4 to 6 weeks, is our engagement across the organisation and across all of our 3 sites. So that's Mansfield Community Hospital, Newark and Kingsmill. And we've been doing health and wellbeing roadshows where we've been engaging with the leads in clinical areas and non-clinical areas with regards confirming our offer as an organisation around health and wellbeing. And how colleagues can access that, whether that's on a one-to-one basis or whether that's more of a rapid access and support basis. And I would say that those have been very successful. The feedback from colleagues has been very positive, and I think it just emphasises that there is a need for us to continue to support colleagues in their wellbeing and welfare. And as an organisation, we continue to be absolutely committed to that, to engage, listen, and to make sure that we're actively involved in clinical and non-clinical areas. So I think today, over the last 2 to 3 months, we've done over 50 road shows, and up until the end of March, we've got just under another 20 road shows planned. And again, those are at a service level, a team level, and those are also based on requests and where we think there's the most critical areas of need. So we will continue to do that and provide that support. Next thing I wanted to update is with regards to being piloting wellbeing conversations. What that means is we've developed kind of a package and a training opportunity for colleagues to learn and understand and to increase their capability of having a good wellbeing conversation. And that has been with regards how to do that, what to be mindful of, and also the actual conversations to have. And we're just evaluating that pilot and then looking to do a full rollout from that learning and to embed that as part of our appraisal process, but also just to embed that in terms of ongoing conversations about colleagues' wellbeing. And that is part of the NHS People Plan, and that's a key initiative for all organisations to introduce. And we was very hot on the heels with that one in terms of putting that into train. So that will continue to be rolled out across the organisation. The last thing I just wanted to highlight is that we have mentioned before, we have put in additional psychological support across the organisation, particularly to areas who have had increased demand and the pressures, so such as critical care, respiratory, emergency department, but also any other area where we've seen an increase in demand and pressure on colleagues. What we've also recently explored and will be introducing from next week is those colleagues that will now be going back to their areas where they originally worked, and they've been working and supporting those areas of critical need due to COVID. We're looking at wrapping around a package of support about how those colleagues can safely transition back into their areas and to have the advice, support and information to hand. So that's something that Claire and I have been working with, such as Julie Hogg, our Chief Nurse, on in terms of putting that package of support together. So again, I think I just want to emphasise that we continue to have a strong offer in Sherwood, but we continue to be flexible. And I think the more that we learn and understand and engage, the more that we can adapt our model so that it supports colleagues, which we know is also going to continue to be challenging over the coming months. So those are just some of the key things that I wanted to highlight. Thank you. And apologies if the sound on my microphone wasn't good before. So any questions, do please ask.
Thanks, Emma.
We'll move on to you, Claire, then take questions.
Yeah, is that okay? Yeah, so I'll just follow on from Emma. So overall, as Simon alluded to earlier in the board meeting, we continue to have capacity impacted by sickness absence, particularly compounded by COVID absence, which takes the percentage up. And then on top of that, there are people isolating. Whilst those figures are now starting to come down, these things have taken the toll, and it's important that we do continue to track them and, as Emma said, continue to support our staff in the ways that we can. Emma touched a little bit on clinical psychology. I think one thing that I do just want to flag is that We are now starting to see, both within Sherwood but more widely, some of the psychological impacts of what we would call wave 1 of COVID. So if you think about when that was, they are now just starting to take effect. Moving on to vacancies. Vacancies remain low, a consequence of a downturn in turnover and also continued onboarding in terms of recruitment, which we've continued to do throughout. Whilst appraisals is lower than our target, I think it's an important indicator just to refer the board to, because 87% overall I think is still quite a good achievement in terms of appraisal uptake, given the kind of year we've had and the position that we've been in. And the final point from me is the other vaccination, and that's flu vaccination, is to say that we've done our final return now, so February signals the end of the formal programme around flu, and in terms of our frontline staff, we submitted a return of 87.4%, which is the highest ever uptake that we've had. Thank you.
Thanks. Manjeet, I think you had a question, didn't you?
Yes, thank you. I was just going to say, first of all, that the apprentices recruitment is really impressive, and you know, it's an important part of our recruitment, and I didn't want us to lose sight of how impressive that performance is. My question really is around the sickness absence, because we don't have the peer group data. That stopped a while ago, understandably, because of COVID. How do we compare? You know, how do we know, you know, how we compare to others? So that was the key thing, and I just wondered if maybe we could take a deeper dive on the sickness absence when we have our people committee. Thank you.
I can just respond to that, to one of those points on the sickness absence, if that helps. So Manjeet, yes, we can definitely do a deeper dive. I think it depends on who the comparator's with, because if we take a regional, as in a Nottinghamshire and our bordering counties comparator, and against similar organisations, then we're all in the same range on our absence, particularly the absence impacted by COVID. If you start to move to other regions across the country, that varies, and that's varied as we've seen higher community prevalence around COVID absence. So when London and the South East, the infection rates rose, there was a correlation, of course, within the hospitals where it rose, and we didn't necessarily see the same spike at the same time. So yeah, we can have a further look at it, but I hope that helps give some context.
Thank you. That's really interesting, of course, thinking about the correlation with the infection rates generally as well. Okay, thank you.
Tim?
Thank you, John. Thank you, Claire. I just wanted to come back to the observation around appraisals, and I fully appreciate and understand why we're at the percentage we are. I just want to ask a question, because I think appraisals are important, whereas if we've got the culture and the environment right, it's an opportunity for our workforce to input into the organisational culture going forward, rather than for the management to direct the culture downwards. So for me, it's important that we get the appraisals back on track. And my question is, do you have a strategy or a timetable, or do the people committee have something in place ready to push the button when the timing's right to get this back on track?
So Tim, yes, we do, and I think that plan has changed throughout the year. So as you've quite rightly referenced, we actually stood down appraisal activity. So all non-urgent and essential activity was stood down at the start of the pandemic, last March/April time, and we originally had a trajectory to get back on plan towards the end of the calendar year. We moved that again towards the end of this month. So we are working towards that, but I think it's fair to say that will now stretch into the summer months because of the because of the wave 3 that we've experienced and the standing down again of the activity. I think for me, what's really important to reflect is the fact that actually overall our position is still relatively good. So we still are having those appraisals where it's where we're able to do so, and I'm pretty sure that we will be able to catch up as soon as people can return to both their substantive jobs, and also we've got increased capacity to undertake them.
Thank you.
Okay, thanks. Richard, I think that's all the questions. Back to you.
Thank you. Anything else from anyone? Okay, thanks Emma, thanks Claire. Can we go over to, I think Julie, you're taking the lead this month.
Yep, thank you. So I'm going to kick off and then Dave will join in. So we just want to bring 2 metrics to your attention this month, please. The first one is C. diff. So we've seen an increase in month in the C. diff rates again, although when we compare to this time last year, we've had 29 cases in total compared to 31. We continue the work that we've talked to you about previously around antimicrobial stewardship and just looking at the patient factors that make these patients more at risk of developing C. diff. And we'll continue to work with partners because this increase in C. diff is not a problem unique to Sherwood. The ribotyping has been completed to see if we'd had any transmission between patients, and the results that have come back to date show that that is not the case. The second metric to draw your attention to is the definite hospital onset COVID infection. So these are patients who've had a positive COVID test at least 15 days after they have been admitted to Sherwood, and we've seen an increase for this in January to 34. I think it's fair to say when we look at the data regionally, we're not an outlier for this, but there is room for improvement. And we're working through the board assurance framework for infection prevention and control. There are 102 key lines of inquiry within that, and we're fully compliant with 100 of those. The remaining 2 are around IT solutions, and we're progressing those at pace as well. And the quality committee will look at the BAF on the 8th of March and report up to the board of directors for the April board. Dave, do you want to add anything on that?
Thank you, Julie. The only couple of things I might say is that just for board's awareness, there has been some recent direction from NHSEI about classifying these hospital-associated infections and doing some SI work on them. This is something that we'd already flagged, and obviously we have concern about this. It feeds into some of the conversations that we had right at the beginning of board around the outbreak management. All of the positive tests undergo root cause analysis, and it has taken us a period of time to get through those root cause analysis because of the ongoing pandemic workload. What we are unclear at the moment is the harm associated with these hospital associated infections and whether there is harm associated. And I think it is likely that we will categorize this into 3 groups. We will categorize it into groups where patients have acquired COVID within our organisation and have come to some harm. There will be another group where patients have caught COVID and have come to no apparent harm that we can tell, and then there'll be a group in the middle. And so the team, so this is cut across clearly Julie and my portfolio, will have to start to do a significant piece of work on this and a look back a piece of work on this. And I would just perhaps note or ask board to note that when we went through wave 1, there were clearly hospital acquired infections, but we had no sight of those really because our ability to perform the screening tests, our knowledge of the disease was so different in those days. And so we continue to learn week by week about this condition, what we need to do and how we can change things. And I think that's the key bit of doing this investigative work. So I'll stop there. Happy to take questions.
Barbara.
Thanks very much. So I noted in the papers, obviously there have been these 80 cases, but you said that a significant number of the cases had missed their day 3, 5 and 7 COVID swabs, which means they may not be true nosocomial cases. I wonder whether you could just explain to the rest of us who are not living and breathing this all the time, the implications of those missed swabs, please.
Sure. Shall I go, Dave? So I think essentially what we have done is missed an opportunity to identify that a patient's had COVID earlier on in their journey. So as the guidance came in to implement the swabbing on day 1 and then day 3 and then a further swab between day 5 and 7, we were busy implementing our systems to get this in place. As we've matured, we're now able to look at our compliance with doing that. And I think it's fair to say when we first looked at it, compliance wasn't where it needed to be. It has improved significantly over the last 4 weeks or so, and we're about 75 to 80% of patients that we're compliant with. That data set is not always straightforward because we have to exclude the patients who are already COVID positive and don't need another swab. So it's something that we're working through, but we're getting much more visibility over it. But essentially, we've missed an opportunity to identify some patients who potentially had a community onset COVID, but we didn't identify it.
Thanks very much for explaining that, because I think that gives you some parameters around that figure of 80 that perhaps aren't initially apparent. Thank you.
And Barbara, if I could maybe add to that, so that requirement for the additional testing of a swab came in the autumn on the understanding that as our swabbing capacity as the NHS organisations increased, we recognised that actually a single point of contact swab was missing a number of COVID positive patients, and so it was doing that second swab at day 3, and to give again a bit of flavour of the complexity of course what we're doing now is we now have rapid point of care testing in ED with our patients, and then we also have our PCR testing. So it's that putting that complexity and ensuring that all of those systems are talking to each other and we have sight of.
Can I just ask, the rapid point of care testing in ED, what methodology is that test used? Is that PCR or lateral flow?
It's PCR, it's not lateral flow.
Good. Thank goodness for that. Thank you very much.
Yeah, the only area where we've been told to use lateral flow for patients is for birth partners in maternity.
Oh, okay. Thank you. Thank you.
Just some organisations, Barbara, who haven't got the ability to PCR in ED are using lateral flow for ED patients as a better than nothing, but we're using PCR.
I agree, better than nothing, but I'm glad that we're using the gold standard. Thank you.
Simon.
Yeah, I just wanted to make a point on the point of care, Barbara, that is just for patients who are admitted. It's not every patient who comes into the ED.
Okay, thanks.
Thank you.
Okay, Richard, back to you then.
Thanks, John. Thank you, Julie and Dave. So as colleagues know, our focus is on getting people into a good place from a working perspective. That translates into safe, high quality care to patients. And then we know that access is a key determinant and indicator of overall quality and safety from patients. So Simon, over to you for access, please.
Thanks, Richard. Just a few points to pick up as a method of introduction. Emergency access, it dipped a little bit during January. That was mainly related to, that was sort of peak time in terms of the COVID surge, and I've reported to board before the complexities that brings in terms of bed access and the number of moves that need to take place and cleaning and all of that. But I think it still remains strong. It was ranked 22nd in the NHS, and it certainly bounced back in February to 92%. So I think we're doing well in that area, and ambulance turnaround is the best in the EMAS region. So that's very positive. It's also been positive that we've opened up the first phase of our expanded ED with the ambulatory care unit that's been opened, so that remains positive. And our next steps are around urgent care are of course planning for Easter, which is only a month away, and the next time we meet we'll sort of, you know, we'll be into Easter, continuing the work with that ED programme. And then, as discussed at the board workshop, some of the nuances around what our future operating model might look like around urgent care to sort of manage COVID as one of the sort of like normal illnesses that we would manage as an organisation. So that's a point on emergency care, and I'll pause for any questions on that. Doesn't look like there are any. Moving on to cancer care, so it was slightly outside of our predicted range, which was 70 to 75%, but the average weight and the 85th percentile weight for cancer treatment remains similar to pre-pandemic levels. We have got a risk in that we are seeing some increase in demand on the cancer pathways, and it looks overall like that is delayed demand, which might be been held back from primary care. So, for example, in December we saw a 20% increase in our referrals on the 2-week wait, but across the year overall referrals were 15% down. So that does create a few challenges for us on that cancer pathway. There are a few things that we're doing around that, so increasing straight to test, so to try and take out where it's unnecessary that first outpatient appointment, get patients into tests straight away. But a lot of the capacity requirement will be on those diagnostic testing areas, and we're going to have to prioritise some of the cancer tests within that, which may lead to longer delays for routine patients who are waiting for imaging and the like. And then obviously we are managing to get cancer patients in for their surgery within the constrained operating capacity that we've got at Kingsmill. We're also working with primary care to just make sure that we've got a really good understanding, practice by practice, of where the demand is coming from, and make sure that all of that demand is appropriate. So there's a bit of work to do there, and we might be seeing a start of a wave that might be coming of patients who could have been referred during the pandemic surges but haven't been, and therefore are now being referred. So I'll pause there on cancer if anyone's got any questions. No? Okay, and then elective waiting lists, they remain relatively stable, but of course, as previously reported, they're about 10,000 higher than pre-pandemic levels. Activity is stable at 80% across the board, but at 40% in Kingsmill theatres, as previously reported, due to critical care surge. We've got a good, robust process for prioritisation of who gets into Kingsmill theatres, so clinically led, with clinicians meeting daily to decide the theatre lists for the coming week and which patients are the highest clinical priority to get onto those lists, which is working well. And Paul mentioned earlier the term time critical surgery, and they're largely patients who are given a prioritisation to. Within that, and just to give you a bit of a flavour of where we stand in the region on that, so we've got the highest number of P2 patients who've got a date for theatre in the region, and we've also got the lowest clearance time. So in effect, that's how many patients have you got waiting against the activity that you're doing each week, and it tells you how many weeks it would take to clear that group. We've also got the lowest clearance time within the region in that P2 group. So I think within the constrained capacity that we've got, we're making decent progress within that area. There's a lot of work to do in this area during March, as we touched on at the board workshop, about what our future operating model is to make sure that any future COVID surges we should see in critical care, should we see them, and minimising the impact that then that has on theatres. And that's a very complicated operating model to pull together, but we'll be doing that over the next month. Even though COVID prevalence is reducing within the organisation, we won't be restarting much of this work in theatres until after Easter. That's largely because critical care is still in a surge state, but largely, as Emma was mentioning, there's a package in there for colleagues who are coming out of these areas to make sure they can get a bit of rest, update mandatory training, get back to their normal job plans and the like. So that's a position on elective waiting lists. I think Neil's got a question.
Yeah, thanks, Simon. Just looking at the 52-week waiters, there's been obviously quite a big increase in the last few months for reasons we're perfectly well aware of. And whilst accepting that cancer is a priority, do we have a plan as to when we can get that back down to zero? We worked so hard to get it to zero, and it stayed at zero for about 15 months, and now it's gone up. And is there a plan to get that back down to somewhere where it's back down to zero in the next few months?
Yeah, so it's unlikely to be back down to zero in the next few months, Neil. I think that all the work at the moment is about treating patients with the highest clinical priority through that theatre capacity. I think that when we get into a position where the only thing with those 52-week waiters is if their clinical prioritisation moves into P2, then they'll obviously get treated within that. I think as we move through the year, we will have a clear plan on what we do to reduce the number of patients who are having long waits, and a lot of those are in more routine categories, yet important categories like orthopedics, ophthalmology and other areas. And I think that as we develop the operating model over the next month, we'll have a lot more clarity about where we get to with the 52-week waiters. But I think we've got to be realistic that there's a huge amount of patients that we've got to treat through theatres, and we've got to develop that operating model to have a clear plan. We're also not sort of clear nationally about where the priorities will be at the moment, so that guidance will come. But if any of those patients get their prioritisation level moved, we will treat them in the theatre capacity we've got available.
Simon, I just wonder for members of the public if you could just say what you mean by P2 patients.
So a priority 2 patient is a patient who requires treatment in the next month, surgical treatment in the next month.
Okay, thank you. Richard?
Yeah, I was just going. I meant to mention it in the opening, but I realised I didn't. Just building on what Simon was saying, I think, and it ties back to Neil's question. I think there's a lot of work for us to do to explain where we are, and then the steps that we're going to take over the next couple of months to explain to colleagues within the organisation, but also to patients, because there are a series of standards that we have understood now for many years, that I think at the moment are relatively meaningless. So we have to be clear about where we think we can get to. Simon was describing the work that took place sort of leading up to October last year within Sherwood was pretty successful, because we enabled the people heavily involved in service delivery to determine what they felt they could achieve. And then Simon was describing us to yesterday, our trust plan was based around all the individual service plans being amalgamated up, and that's the process we're going to follow. And the communication internally will continue. And then, as people know, each month we have sort of a question and answer session out to the wider communities, and we're going to take the opportunity at the end of March to communicate effectively to people on waiting lists, etc., about what they can expect over the coming months. Final point for me, I think, as Simon was saying it, though, we do have to be pragmatic and realistic about the wider NHS and therefore our ability within that to see in the short term dramatic reductions on volumes of patients, say for example waiting over 52 weeks. And I was just checking, there was an interesting article in the HSJ yesterday about why it's got to be raced around clinical need, in particular those P2 cancer patients, etc., as opposed to a focus at the moment around the longest waiting patients on elective pathway. So I think we're making progress, but there's clearly lots to do.
Okay, thank you.
Yeah, I think the other point just to make on 52-week waiters is that albeit it's a very long wait for those patients, and we'll do everything we can to bring them in. It's 4% of the waiting list at the moment. So I think the key bit is trying to sort of minimise the number of patients who fall into that group as well.
Okay, thank you, Simon. Is that end of your report, right?
Yep, thanks, Chairman.
Thanks. I mean, clearly a lot of work going on, and I think it just reflects some of my comments as part of the chair's report, that actually we're entering a period of time when there's lots of moving pieces, and we're going to have to think very carefully about how we balance all those and make sure that we're providing the best service, but we are going to have to prioritise some things, aren't we? So I think that was some quite good examples of that. Yeah, thank you. Richard?
And then over to Paul, please, for the fourth of the 4 domains money.
Thanks, Richard. So in terms of financial position at the end of January, we are reporting a deficit of £3.9 million, which is £1.3 million better than the plan we submitted at what was called phase 3. What we have to note there is that phase 3 plan was not agreed by NHSI, and we continue to work with NHSI, and I'll come on to that in a minute. Within that deficit position, there is total expenditure of 329 million, of which 18 million is directly as a result of the COVID pandemic and has a separate funding source, and 1.5 million as a result of our work on the vaccination programme, which again has a separate income and funding source. Our forecast as at the end of January is a total £9.8 million deficit, which is slightly worse than the plan we submitted by £500,000. And this is following NHSI advice on what they're calling allowable issues within bottom lines. For example, the change in the annual leave creditor. We know that staff have been unable to take all annual leave allowances for the year, so we need to reflect that in the year end. And there's also more advice coming from NHSI on allowances and potential cash payments for where we have lost the ability to recover non-NHS income, and indeed the impact of the non-recurrent actions that we took in 1920. In terms of capital expenditure, we're above plan at the end of January by 1.3 million, and that includes the expenditure on items that weren't in the original plan but being funded separately, ED expansion and COVID related items and others. And we expect to exceed the plan by the external amounts that we receive in total by the 31st of March, which will be 3.2 million. Leave it there, John.
Thank you, Paul. Graham?
Thanks, John. Paul, it's not so much a question, more a commentary. I'm struggling a little bit with the SBS graphs, which cover the finance area on pages 20 and 21 of this pack. It's really difficult to work out what they're telling us. And the procurement one doesn't tell us anything at all. But even the other ones, it's really difficult to understand what they're showing, or it is for me anyway.
Yeah, so the procurement league tables hasn't been updated, and that's why it looks like a flat line, Graham. And we agreed when we refreshed the SOF this time last year that would be a key indicator. We're in the process of reviewing the SOF again for the future. It may be that is not something that we find particularly helpful, but we'll have a further discussion on that. I think the other graphs reflect the expenditure and financial positions that I've reported. Certainly on the capital one that I'm reporting, and the underlying performance against FIP that you will recognise as member of the Finance Committee. I haven't drawn that out in the narrative of the report or in my verbal update, as I'm not sure that they are material aspects for our current financial position. But again, we can review the continuation of those graphs in further iterations of this report.
Yeah, I think it's just a reflection of whether SBS really works for showing some of these numbers. I recognise the trend in terms of capital expenditure, and we're going above plan, and it's showing that, although it doesn't give absolute numbers in that sense, in an easy way to interpret. And I think that's the problem I have with the other ones as well. It's showing just pretty much flat along the lower limits or just below, and it's to anybody else, what does that actually mean? And that's where I was struggling a little bit with them. No problem with your text, by the way.
Thank you. The COVID regime hasn't helped either. So because we agreed a number of key indicators before the change in the financial regime, so you know we lose a little bit of context there as well.
Yeah, it's maybe something to have a think about how we present these, particularly when we go into next year. Thanks very much.
Thanks, Neil.
Thanks, John. I just wanted to make a comment really rather than a question. I think it may help the board if we actually separated out the FIP achievement into the elements that are down to what I call accounting, movements in provisions, which I think can cause confusion amongst non-accountants, and what are the real cash deliveries. At the moment they're mixed together, and I think when we have changes from NHSI talking about they're going to allow a particular provision or ignore a provision, people normally glaze over. I think having that separated out would be quite helpful for the board to understand what the underlying real savings are and what is down to accounting.
Yeah, I think that's a helpful comment. Maybe Paul, you and Neil can give some thought to that about how we understand some of this, because there's so many moving parts in the finance at the moment. The more we can understand it, the better in simple terms. Thank you.
We will try our best.
Yep, thanks. Richard, anything else on the SOF, or is that it, do you think?
I sense that's it. Thank you to everyone for your updates.
Right, thank you very much. HSMR. Dave.
Thank you, Chair. So this paper provides an update on our hospital standardised mortality ratio and the schedule of work proposed, and it builds on the original paper that we presented to Trust Board back in December 2020. It describes significant progress in reviewing and understanding our processes. And whilst potentially we could take some reassurance from the fact that the HSMR has declined slightly and appears to have stabilised, I would counsel against that. And the reason for that is that, as you'll see in the paper, where more themes are described, our work is uncovering really a number of aspects where I think we can strengthen and the reliability of our outputs, and particularly the learning from the overall mortality surveillance review process. Not surprisingly, I would say that we haven't uncovered a single cause for our raised HSMR, but having said that, I don't think any of us anticipated we would this early in the process, albeit a single cause. I think I'll just highlight two final aspects, and that is that I would ask Trust Board to recognise in the data presented in the paper that COVID has acted as an additional compounding factor in our understanding of HSMR. Sherwood Forest is not alone in this, and this is a national problem, and it will take us a period of time to strip that data and to put that data in context. And I think the other point I might just raise is that the likely outputs from this programme of work, as described in the paper, are very likely to involve significant cultural change for the ways that our teams work, as opposed to a single process change. So finally, with Board's permission, I take the paper as read and ask that we continue to report as agreed in the paper and the reporting structure. And I've brought along Nigel to just help me with any of those tricky questions that you might have on this.
Okay, any comments, observations? Barbara, as Chair of Quality Committee, anything you want to add before we Open it up, yeah.
Just that the Quality Committee are well cited on the work that Nigel and the team are pursuing. So yeah, and we look forward to being kept abreast of that. But I did have a question actually, Chair, if I might.
Yeah, fine, yeah.
And I might have asked this before, in which case apologies in advance, but in the paper, it makes reference to us having one of the lowest or the lowest palliative care coders nationally. Now, that's not a new event. We have historically been low coders on palliative care, as I understand it. Therefore, I just wonder, whilst it's of note, it's not going to explain our HSMR going off piste, if you like, because it's been consistently a low coder. Is that the case?
That's correct, Barbara. Yes, it's something which we are aware of, and we've been very cautious in how we've tried to explain that. So we've not gone down the sort of rabbit hole of saying that this is the answer. But I think if you look at that sort of first graph that I just put up, there is clearly something there which is saying that our HSMR is stable. We are noticing that others may be sort of more variable in their HSMR, and what we are trying to say is that with things like the palliative care, which has always been something there in the, let's say, in the background, if we were to see a resolve in the way that we coded our palliative care, and this, let's be clear about this, it is likely that we are carrying out activity in terms of reflecting on palliative care needs of patients, but it's about documenting that, and it's also about ascertaining whether it's specialist palliative care involvement that's required. And if we get that, then there is no doubt about it that it is felt that our HSMR will wholesale actually reduce down to a level that is more akin with our regional peers. So in the sort of past or historical, you're absolutely right. It doesn't explain why we saw an increasing trend, but what it does help to help us consider is that our HSMR, if we maintain a level of stability, would actually therefore come down to something that is more akin to our peers.
Okay, so sorry, Chair, can I ask a second question?
Yeah, of course you can.
Which is more about it's quite a comprehensive paper with quite a lot of detail in it. Of all of the things that are either underway now or planned to be undertaken, which of them worries you the most in terms of the level of challenge, be it cultural change or whatever? Which is it that's your worry?
So I think Dave's hit the nail on the head here, and it is around culture, and I think that sort of marks off or ticks off several of those sort of 6 significant groups that we looked at. There is no doubt about it. If I was to sum it up, I would say the first 24 to 48 hours of care in this trust are the thing that we need to really focus on. That front door element, which is getting investigations promptly, it's making sure we've got that senior oversight and decision making to a point of diagnosis. So when we talk about we mentioned in a paper before about the GI hemorrhage that several were reported as not being GI hemorrhages. They were documented as GI hemorrhage of some form. My point is that it's whether that was correct. And so I think it's about making sure we've got that senior clinical oversight and decision making, access to appropriate investigations, and when we've got access to them, actually using them. So it's one thing, I think we have got access to them all. It's about whether people are using them correctly. I'm really pleased to say, actually, and I was hopeful and fairly confident that I could help support the engagement, but I've been really warmly received. Probably that's a long history of my relationships with some of these consultants, but I've been able to use that. And I think with the ME position as well, I've got to keep them very separate, but it's allowing me to challenge some of those areas, and it's given me the insight. So I'm certainly not the answer, and I worry that my limited time on this is a much bigger thing, and it's organisational, so it's going to take some thought about how we try and look at that whole culture approach. I don't think there's huge things that we need to drastically change, but I think that it's a small thing of culture, but it's a huge opportunity, and I think we've really got potential with this, but it will take time.
Thank you.
Okay, that's helpful. I mean, just to say, I think it's really important from the board's perspective that we clearly understand the impact of the coding, but more importantly, that we understand why we've seen the increase. because I think the increase isn't because of coding, is it? It may be that the relative position we are in can be addressed to some extent by doing the palliative care, coding the palliative care exactly as other organisations. But as Barbara pointed out, regardless, we did see an increase in it. And I think, particularly as you look further forward, as you said, and if there's culture or whatever it is, actually that we really understand what happened then. So I think it's, you know, I know it's sort of some places sort of you change your coding and then problem solved. Actually, I don't think we should be assuming that's the case. You know, if we change the coding and HSMR gets better, then we can look to get even better because there must have been some other things happening. So I think as a board, we need to keep the eye on that.
Yeah, John, if I can come back in that, so exactly right. So our palliative coding has moved from what was described as bottom quartile down to, I think we're the second lowest in the country now. So it has shifted, but we are, but we can play a game of playing with numbers. That isn't what we're interested in. We're interested in the learning and the change processes, as Nigel has described, and there are some key bits to action this, and that cuts across. It's not just the HSMR; it cuts across our whole quality of care.
Okay, now that's really good to get that assurance that we're on the same page there. Great, thank you. Sorry, Simon, and then Manjeet. Simon.
Yeah, thanks, Chairman. Nigel, I was actually, Barbara asked a question I was going to ask about the graphs and the divergence, so thank you for that. But I just got a follow up as well, which is, you know, what are the top 3 things we've learned since the last time the board discussed HSMR?
I think we've learnt about the importance of transparency and openness. So an example of that will be the fractured neck of femur work that we've done. The first meeting we had, it was almost a standoff with 3 separate areas, you know, your anaesthetics, ortho-gerries and your surgeons. And yet what we've seen is a real collaboration and the opportunities, and suddenly the penny has dropped. And I think we've got a real positive environment with which everyone is keen to try and realise that it's not about passing the buck, it's not about shifting work or resource, it's about actually making the most of what we've already got. Everyone thinks that they're doing a good job, but when they find what everyone else is doing, they're realizing they're probably doing the job of other people's, and we can actually work together. So it's a bit soft, that, and I know that's probably, we wanted more hard facts, but actually it is that culture bit that's really got it. I think there is something around, and without pressing it too much, it is that first 24 hours that it I don't want to say it worries me, but it worries me in a sense, because this is really something around culture, but it's about learning for our juniors as well. So there's something here that we need to have ownership and responsibility from our consultant colleagues, and that's where I guess my challenge is coming into them. It's about explaining that it isn't just a case of them having an oversight and then allowing the rest to happen. It's about actually making sure that they take that forward, and that's something that I'm keen to try and raise through our med managers and through the clinical divisions. And I think this comes into some of the areas which John's alluded to around the HSMR, the trend going up, that I think it would be very easy, or it's been easy in some circles, to dismiss HSMR as just another data point, a number, and it's one of a myriad of things. I think we've got to recognise it is part of a suite. However, there's a reason why we do follow it, and it's got to be telling us something. So I think we have to really answer that question in a little bit more detail if we are able to. We're starting looking at some crude rates, which I know isn't always there, but I think it's starting to highlight where the differences are. So I think one of the important learning points is the fact that I want to almost say I don't just believe what someone has told me in terms of the answer. And I think the more we look, yes, the more we'll find, but I think it's about us being very clear from the start what the question we're trying to answer. And I think if that's really helpful, if that's what you still really need to know, is that why did we increase? I can't promise that we'll get to the bottom of it, but I'm hopeful that we'll get a bit more intelligence to help support that.
Thanks, thank you.
And Simon, if I can add my tuppence. So the other thing that I think is going to come out of this programme is that our Learning from Deaths programme doesn't actually generate learning. And whilst that has been the national directive, and there is concern nationally about this whole programme, but I think we as an organisation can dramatically improve that locally, and that will be one of the key bits that come out.
Okay, thank you. Manjeet?
Yes, thank you. Apologies, Nigel, my camera doesn't work. And
Okay.
what I was thinking about was about, in terms of this, complex suite of measures and what we're doing, what's within our sphere of control and what's within our sphere of influence. And I was also relating it to, here's some further data that at a granular level starts to make health inequalities real, because we grapple with health inequalities at a high level and making it real. And I'll come on to my question, but the third bit I wanted to add was I was also curious about our partners' HSMR rate, which is Nottingham University Hospitals, because they equally serve a highly deprived area as well, and they're 113. So again, an outlier. And I just picked up their learning from deaths report from January, where I picked up. But what I was going to say was, is this an area where we are influencing the system working in terms of what more we can do around that integrated care, the integrated triage process and things like that? So I just wanted to understand more about where integration can also be a factor in terms of our sphere of influence beyond what we're doing. And I agree with all the other things. Thanks.
Yeah, I think that's a really strong point, Manjeet. It's something that I've been really keen, certainly from my background of primary care, of working with the CCG before I came alongside SFH. It's something I was really keen that the sort of almost like the pre-admission and the post-discharge, or the reflection, if we've had mortality, is something that we need to look across the system and the whole patient pathway. Yes, I think we are really keen to see that on a more sort of, certainly an ICP level, and even that ICS right across the county. You mentioned the peers, NUH, and to see how their figures are, and again, it's trying to make sure that we are sort of measuring apples against apples, and certainly something that Dr. Foster and our close working has been, and I've got to say I've been really impressed with the collaboration we've had with them, being careful to note that they're in it for one thing and we are wanting to get certain things out of them as well. But actually they've been really strong in terms of their response to some of our question and lines of questioning, and they've been able to offer that intelligence to, and almost an assurance for us, or they've been relatively impressed with how we've been on top of things compared to peers, which is I think why they are suggesting we've seen a relative sort of levelling, whereas certainly there are a number, he said, which are of regional peers, but also nationally, who are now seeing over the last 2 to 3 months real issues in their HSMR spiking beyond sort of all initial belief. So I think there is something here about the ICS, again, still relative infancy, but I think there are some real seeds of potential fruit here, and I've got a good relationship with certainly our ICP clinical lead, Tilan, and there are things that we're trying to do right across the board, including access to sort of outpatients, and it's those bits so we can try and prevent the admissions, but also to make sure that they are appropriate, because obviously our admissions are what drives our HSMR. And so it's not just about looking at those different elements, but it's trying to draw everything together. Again, we're trying to look at things through a whole system approach. So the ME service is taking on the sort of community deaths as well, and I think that'll help us look at the intelligence across morbidity and mortality across the whole system, and how different integration of care pathways have happened, whether that be community services, primary care, or other allied specialities. And there's also that joined up thinking between our partners. We know that there are tertiary specialist areas with our colleagues in NUH and the likes, and that also has an effect in terms of the patient demographic that go or come to us.
And Manjeet, if I can just add, so there are some specific reasons for NUH's data around data anomalies, and we touched on data anomalies at the start of this conversation, and we've certainly had some data anomalies, but just to give you some flavour, so I'm not sure if NUH have tipped into their 4th year of the work to understand their raised HSMR, or if they're still in their 3rd year, but it's been a very long programme of work, and so we're in our 3rd month, so perhaps that is a lesson to us, or a message to us.
Yeah, thank you. Thank you. Just one final question, John. Really, that's really helpful. And I understand, you know, it's sweeter measures and apples and pears. So the work with our ICP, is that helping with more sort of integrated triaging in terms, as you say, the admissions? Because it's useful to have that assurance.
I think at the moment it's still sort of words on paper, and it's been happening to a degree, but I think that there is a genuine desire to see this happen a lot more. So whether that be about utilising the sort of more things like virtual wards that we've been looking at, whether it be around better contact sort of pre-admission or even sort of pre-referral for outpatients, and recognising that actually that patient is in the middle of this, and what we need to do is get off our sort of binary system of we are hospital, that's community, and it's actually recognising that we are all responsible throughout that pathway for the best care of that patient. And that seems to be a sort of a common thread throughout a lot of the discussions that I've either been in contact with or have been sort of privileged to be sort of part of. But I think that's right through sort of through sort of your acute or through the sort of more elective approaches. So I'm hopeful that what we start to see, it might not alter our overall sort of mortality, but we'll start to see a more or a better understanding of the distribution as we start to look at community and hospital. So we need to try and make sure that we have our processes in to understand where we could have improved, but certainly something from sort of the SJR panel that we've highlighted, and certainly what I try and do with the ME service is highlight where I think there has been either an omission or a suboptimal care in one element of that whole pathway. So it could well be community or in something that we have failed to communicate, and that's where we've certainly raised some of those issues.
Thank you. Thank you.
Yeah, Julie?
Hi, I just wanted to follow up on Simon's question a little bit, really, to just think about, is there any changes to clinical practice as a result of this work yet? And then my second question relates to other exemplar organisations and whether we're planning to do any work with them, because we've heard already that NUH is probably not a good partner for this.
So I think, dare I say, personally, I'm a little frustrated that we haven't got further than we could have done. But it's probably the sort of Christmas, the COVID and the culture, the 3 Cs, which have all been that little bit. It's taken some time to get people on board. I think the Christmas period and the sort of that additional sort of pressure from COVID has meant that we haven't managed to get some of those additional sort of meetings. But I'm hopeful that over this next sort of, I guess I want to say sort of probably like 1 to 2 months, that we'll start to really drive some of those changes. Certainly I mentioned perhaps about walkthroughs, and that's the way I think the consultants really like. They like to see it in working. So we can actually walk through that patient pathway to make sure, and I think that's where we'll see the difference. In a couple of areas we've highlighted where there is potential sort of gold standard or an improved standard or recognised standard of care, and I think there is certainly a desire to perhaps consider how they're doing things, but it's about looking at it in the context to say it might work for their population, but not necessarily, it's not always an off the peg thing that we can bring, but I think there's certainly some ideas that it would be useful. From a personal side, again, it's trying for me to work out how I can manage that, or whether it's my job to directly manage, or it's who's going to facilitate that. And I guess this is where I would ask whether the HSMR is something that it does require more that sort of PMO oversight to really make sure, because it does run across the whole system of the organisation.
Thank you. I mean, it seems to me that we need to think in addition of how we continue the work, and that gets really embedded in the trust, and this does take time, and it's not just 4 years at NUH. Barry White in 2001 led a task force looking at high mortality rates. So this is something which is around all the time. And,
it got better
I think
for a
we need
period.
to find out how we make sure that some of this gets really embedded, as well as understanding the things. But thank you very much for your work. Okay.
Thank you.
Thanks. Right, shall we move on then to SFIs and scheme of delegation? Paul.
Yeah, sorry about that. Yeah, there is an annual review of the standing financial instructions and scheme of delegation. This has taken place a little later than we would normally do. There's been some slight amendments, mostly around names, titles change and change of responsibilities at executive and senior level. It's been approved by the audit committee and I present it here for final approval by the board.
Neil, anything you'd like to add to that before I open it up? No. Okay.
Sorry, I don't think so, John. So you caught me unawares there. I haven't got the camera or the microphone on, but
I'm the same as you. I'll keep on doing that. Yeah. Okay.
Nothing to add. It seems to be just a change of titles. Really, nothing of any substance. It would appear to me in the paper.
And John, it's probably me you should have focused on that one, but because it went through audit committee.
Yeah, you are right. Yeah, it should have been you. Sorry.
But as Paul said, yeah, it's primarily changes in titles and things, and yeah, we were happy with it.
Okay, so I can't see any concerns being raised. So can we take that as approval?
Thank you.
Assurance and subcommittees. This time it is Neil.
Yeah, I'll take it this time. Thanks, John. Yeah, I'll take the paper as read. Just wanted to pick up really just a couple of points. The first one, I think Paul's already mentioned in that we haven't got any planning guidance yet for next year. It's been delayed because of the COVID scenario, but we do expect to get that in April 2021 this year, with plans being submitted by June 2021. I think the focus on planning is very much moving now towards the ICS. The targets are going to be set at the ICS level and then allocated out to the individual trusts within the ICS itself. The other point to highlight really is the financial strategy that we set in 2019-20 has almost inevitably, I guess, gone a bit off course because we've had this pandemic to deal with. And although we have achieved the FIP targets in previous years, for the last 3 years, I think it is, a lot of that has come through non-recurrent savings. And that means that the underlying deficit against the strategy is running at about £12 million a year. So there's a fairly alarming difference there over the 3-year period, but that's been reported for a number of months, well, a number of years really. And then the other point to make is on the ICS, there is now a finance committee established. The first meeting is this afternoon. I'm looking forward to going to that and starting to get to understand the plans at ICS level and how we're going to contribute towards delivering at that level.
That's great. Thank you, Neil. Any comments on that? I'm really pleased that the System Finance Committee is now starting to operate, because I think that will help in terms of consistency and transparency, etc. So that's really good, Neil. Thanks. Okay, Tim, charitable funds.
Thank you, Chair. Report has been submitted and taken as read, and there were just a couple of quick items for me to bring to your attention. One is that we have reviewed the purchase of a new financial reporting system just for the Charitable Funds Committee that works around the charities sector, and the committee approved that, and we're just going through to NHSE to ensure that we're okay to go ahead with it. The second one was around the accounts from charitable funds to be reported in a non-consolidated form within the annual trust annual report and accounts rather than separated. That was approved, and it's a practice that the trust has undertaken all the time I've been here. One thing that we're looking for our corporate trustees, we wish to seek their approval, which is around end of life project that we wish to, well, we wish to seek the approval, mainly because the collective cost is over £100,000, where there is a number of areas that we want to enhance for end of life care, and we felt it more appropriate to bring this to you as one bundle. We have resources already available, we have the right project in place, and we have a legacy amount to underwrite the shortfall, but our fundraisers, I feel confident, will also be able to generate funding to bring back in that amount we're looking to underwrite. So we're just looking to seek the trustees, our board's approval on that £136,000 spent.
Okay, thank you. So just to consider the request from Tim about the approval of that end of life service enhancement. I don't see anybody raising questions, or so I'm going to assume that there's approval for that. If anyone's got any concern, can they please type in the chat now? Looks Tim, as though you've got approval from that, so that's good.
Thank you, everybody.
Okay, thank you very much, Tim. In terms of messages to the organisation, I mean, I think we could reflect some of the sort of comments that Richard and I between us made about the sort of transition moving into next year, looking forward, some of those sorts of things. I'm sure a scribe will be able to make it sound much more sensible, put together. So if you can do that, that'd be helpful. I think we need to both recognise the vaccination progress, but also really push for you know, encourage people to have the vaccination, etc., and say some of the things that you're doing to do that. We should reflect on the maternity, and in particular, I think I know we have a bit, but I think we're clear on the role and some of that, and some of the good things, the openness of the culture, and some of those which I think were positive. Across the SOF and the HSMR, we always, you know, I think there's 3 or 4 items that came up there. Not necessarily about, you know, how we're doing, but also about some of the challenges ahead, but also recognising some of the work that's being done in those areas. And then the final point I picked up was we probably ought to just reflect on the fact that we haven't yet got a plan for next year. We're still waiting for the guidance. We're still trying to work it up as best we can, but you know, that's still uncertain. Paul, I'm just wondering, are those the main things? Was there anything else you thought we should add to that?
No, I think they were the main things from my point of view as well.
Okay, so unless anyone else has got any points, is that enough to sort of put out some key messages? Thank you. I haven't been notified of any application of the trust seal. Yeah, there is that. Sorry, Shirley. Yeah. Sorry.
Sorry, yes, this happened quite late on, John. So just to say, this is for board to approve. The seal was applied on the 17th of February, seal number 90, or signed off by Richard and I, and it's about the fire upgrade works at Mansfield Community Hospital. So just need board approval.
I can't see any queries there, so I'm going to assume that's all right.
Thank you.
Thank you. Date of next meeting, April Fool's Day. So we look forward to seeing you there. 1st of April. And I'll declare the meeting closed. I'm not sure if we've got any questions from the public.
Nothing, Chair, no.
Okay, thank you for that. So resolution then to close the meeting, as some of the further discussions are prejudicial and will be taking place in private. Thank you very much, and we'll meet again, say, what's time now? Yeah, 1:30. We're pretty well on time. Is that all right? To just have a talk about 1 or 2 further things. So thank you very much, then.
Thank you, John.
Thank you.
Thank you.
Thank you.
Thank you.